Okay, this next session is research to practice. One of the things we all are struggling with. We're going to start out with Beverly Winikoff from Genuity, who's going to be talking about the research on misoprostol, to be followed by Fernando Altabi, who's going to talk to us about Uniject oxytocin and his ease of use study. And I'm hoping he'll come up here so he doesn't have to come up in the middle. And then we're going to go to Ezequiel Garcia Elorio, who's going to talk about research and how it's informed practice and scaling up postpartum hemorrhage in Ghana. And finally, Matthews Mathai, who's from WHO, familiar to all of us, who's going to talk about WHO guidelines and their data from WHO. So let's start out with Beverly. Thank you.
Thanks.
Everybody can hear? Okay, good.
Yeah. Okay, so I'm asked to tell you about the research on misoprostol for PPH indications. And we're in a really funny place on this technology at the moment because there have been very significant research published on this topic, some of which has been used in reviews of the literature and policy guidance. And there's also a whole series of new research studies that are being published that may or may not change the recommendations. So what I'll try to, and I only have 10 minutes and about 6 different topics under this. So I'm going to really talk fast. No, I'll try to talk as reasonable pace, but I'm going to flip the slides very fast. And the first slide is going to tell you how I've structured this, which is the evidence and the current policy guidance. And within that, then after the current situation, I'll add for your information the results of studies not yet but to be published shortly. And then you can decide whether the policy guidance should be changed or not. That could be an exercise after this. The topics that this is about concern prevention of PPH using misoprostol and treatment of PPH using misoprostol. The treatment of PPH has different aspects, and there's research with no prior exposure to oxytocin for prophylaxis, after use of with oxytocin for prophylaxis, and simultaneous with oxytocin for treatment. So they are very different things, and it's very confusing. So if you're confused, don't worry, just ask, stop me, or ask afterwards. And then a little bit about what next in the research agenda. So misoprostol for PPH prevention, there are several large trials that have provided community-based evidence. Thankfully, they all use the same regimen, which is 600 micrograms of oral misoprostol. So there's a lot more homogeneity around the discussion about prevention, at least in terms of what to use. There is also a new, as yet unpublished study, which will reinforce some of the conclusions that were made with the previous research, a large community-based trial in Pakistan, in which would use 600 micrograms of oral misoprostol or placebo, and recorded markers of blood loss and hemoglobin change that were significantly less in the misoprostol than the placebo arm. So the current guidance, which does not include the unpublished articles, of course, from the Cochrane reviews, is that if conditions for oxytocin use cannot be met, then misoprostol could be used based on current evidence. The WHO recommendations that are in the context of active management, skilled attendants should offer oxytocin in preference to oral misoprostol, but in the absence of active management, a uterotonic drug, either oxytocin or misoprostol, should be offered by a health worker trained in its use for prevention of PPH. So this is it's a little confusing, but it actually seems to be, with some thought, clear, but it's a little sophisticated, so sometimes hard to figure out for a particular situation. Now for treatment, we are in a really different place because the existing published evidence is much less consistent. It's much less consistent in its findings. It's much less consistent in the application, in the dose, and in the circumstances. It has been documented in the literature for 3 main uses in terms of treatment itself. First of all, as the treatment, the first offer. When somebody has a problem, you give them misoprostol. That's primary treatment. The second is adjunct treatment along with other oxytocics. In other words, you throw everything but the kitchen sink at the woman because she's bleeding and you want to do anything that will help. And is it useful to use misoprostol in that circumstance? And finally, as a last-ditch effort to save a woman's life in a circumstance where you've tried everything you know or have the capacity to use, and there's nothing left, and you just use misoprostol however you think you could use it, in very variable doses and routes, etc. The conclusion in the literature about all of these, based on a literature review, is that there are insufficient data to support a specific misoprostol regimen for treatment of primary PPH, either following or in absence of prophylactic uterotonics or as an adjunct to standard treatment. So there's no regimen that's really reliably studied. The previous literature is small. There is some controlled study. There are some studies that are not randomized and they're ecological. There is some recently completed unpublished research which was not used in the previous conclusions. So there have been 2 hospital-based double-blind randomized placebo-controlled trials where over 1,700 women were randomized to either 800 micrograms of sublingual misoprostol or 400 IUs of IV oxytocin. And these studies were carried out in 5 countries listed here, and were divided into 2 distinct studies. One in which oxytocin had been used for prophylaxis during the 3rd stage, but the woman nonetheless had a hemorrhage. And the other was when no oxytocin was used either in the 2nd or 3rd stages of labor. In other words, the woman was naive to oxytocin and treated with misoprostol for her hemorrhage, versus treated with oxytocin. This is the result of the 2 studies. So these are not published yet, but this is pre-publication information. And as you can see, where women have had oxytocin prophylaxis, there's really no difference in the response to treatment with either oxytocin or misoprostol. And the mean time to cessation of bleeding is just about the same with misoprostol or oxytocin, 19 minutes. But when women have not had any prophylaxis, my oxytocin is slightly better than misoprostol, but I point out to you that even misoprostol is at least as good as either drug is in the first instance. And in the second instance, the time to cessation of bleeding is faster for both drugs than it is for either drug in the instance in which a woman has had prophylaxis. So treatment response is better and faster where women have had no oxytocin prophylaxis than where they have had oxytocin prophylaxis, which is another conundrum that we can think about. We've put this information into a kind of a flow chart to show you what happens per 1,000 deliveries with the different choices of treatment and of prophylaxis. So if you have 1,000 deliveries, you would expect 3% to have PPH if they've had oxytocin prophylaxis. Therefore, you would get 30 postpartum hemorrhage cases out of your 1,000 deliveries. If you treated them all with oxytocin, you would end up needing further treatment for 3. And if you treated them with misoprostol, you would need further treatment for 3. So this is what I showed you before. It's the same. If you have had no prophylactic uterotonics, you would expect a 10% PPH rate, and you would have 100 cases of PPH to treat. And if you use oxytocin, you would successfully treat 95 with 5 referrals or further treatment. And with misoprostol, you would treat 90 with 10 referrals or further treatment. In other words, misoprostol is not as good, but it treats 9 out of 10 people who do have bleeds. So now that's the newer evidence. It's not included in the current recommendations. I'll move on to the adjunct treatment, which is using both oxytocin and misoprostol at the same time.
1 minute.
Okay. So I'll tell you. This is too much of a mess to understand what's going on. This is a new study that is not yet published, which shows, and I'll give you the bottom line, absolutely no benefit of adding misoprostol to IV oxytocin alone for treatment of PPH. Nothing, nothing, nothing. And more side effects. I'll skip that. The current evidence is not robust enough to recommend replacing oxy with miso for first-line treatment. Maybe we have to reconsider. Similar recommendations from WHO. A bunch of information gaps. And one of the things that we want to let you know is that there's new work ahead, and that thanks to the Bill and Melinda Gates Foundation, we'll be able to start a large new 5-year effort to expand on this work and try to answer some questions. Here are some of the things we hope to achieve in this ambitious list of things that are going on under this new initiative. And here are some of the partners we'll be working with. And thank you, and we hope to see you soon.
As you all see, this format is pretty challenging for complex data. Thank you for clarifying, first of all, the distinction between prophylaxis and treatment, and to give us a hint about what's coming. We all look forward to the new publications. So I'm going to ask you to hold your questions until the end, because Matthews has a plane, and so we will take his questions first after we hear the other 3 presentations. So Fernando, who's behind me, who's going to be talking about the ease of study use of oxytocin uniject.
Thanks, Emily. Thanks, Linda. So, good afternoon to everybody, and I'm extremely pleased to be here, mainly in this kind of a celebration of POPPHI success. So, thanks for the invitation, and to everybody, let's say, for being here. So, I will try to very, very briefly present a small demonstration research project that we have conducted, let's say, 1 year ago, and recently finished in Argentina. So this is uniject training and reminders to increase the use of prophylactic oxytocin in the context of active management in Latin America. So the origin of this project was a previous one that we developed a few years ago, and that was a behavioral intervention to improve, let's say, the adoption of evidence-based clinical care, specifically, let's say, the use of active management and also the reduction in episiotomy rates. This was a trial conducted within the context of the Global Network for Women's and Children's Health Research, directed by Linda Wright. And let's say it was published last year, as I'm going to show. This particular trial had the objective to design and evaluate a multifaceted intervention, behavioral intervention, to facilitate the adoption of evidence-based practices in Latin America. And we tested a multifaceted intervention, mainly combining different components that have been proven effective, let's say, to increase the use of, to introduce, let's see, or implement guidelines, clinical guidelines. Mainly the selection of opinion leaders, guidelines, training workshops, interactive workshops, the use of academic detailing, the use of a practical training using anatomical models, the Japaigo model, and the use of reminders and audit-on feedback. This particular combination has been proven effective, and as you can see, it was a cluster randomized trial conducted in 19 countries, in 19 hospitals in 2 countries, and from a very baseline of 2% use of prophylactic oxytocin, 2 years ago, the intervention hospitals increased to 83%, and while the control hospitals remain in 12%. So, and after abandoning the hospitals for 1 year exactly, we left completely hospitals, we came back and we measured again the use of prophylactic oxytocin, and the difference was still there. So it is a sustainable intervention. This is the publication in 2008. And after that, we imagine the dozens of questions that appear. So at least a couple of them were, was this intervention, let's say, feasible in other settings? And also, can the observed effects, let's say, be replicated? And a second one was, okay, can we simplify the intervention and still show some effects? Luckily for us, suddenly appeared Deb Armbruster. And Deb was quite, yes, definitely. She was extraordinarily supportive, let's say, to us, and very interested, let's say, to answer these particular questions. The first one will be answered, let's see, this is a Cameo project that Deb has already mentioned, and Ezekiel will show some of the experiences. And the second one is this Uniject plus 2 other components activities that we conducted. This particular project gathered, let's see, we try to simplify this complex intervention in 3 components, mainly the use of Unijects. At the same time, we began working, let's say, with Steve Brook and also with Patricia Lopez from Biola, Argentina, that they were developing, let's see, the Unijects with oxytocin. So we included as part of the intervention, together with a very, very short workshop, very interactive short workshops to train birth attendants in the use of what's the evidence of prophylactic oxytocin, how to administer, using vials, syringes, and using Unijects, both ways. And you use the Japaigo model also to train anatomical models, checklists, and all that. 2-3 hours training. And also the use of reminders. So we use the posters that were prepared by POPPHI, the Spanish versions, and we posted in different places at the hospitals. How this we tested? This is not clearly rigorous research, high quality research. The previous one was. This mainly because we lack of funding, unfortunately. But we use, let's say, before and after design, a very, very simple one, trying mainly to do a kind of pilot study that perhaps could later, let's say, be reproduced in a better way. We initially selected 5 hospitals in the northern province of Argentina that I will show you now. We began working, let's say, and we did a kind of seminar presenting the project and what is active management. And then let's say, we conducted a kind of a baseline collection data period during 6 months. Then we, let's say, implemented intervention and measured after, let's say, 6 months later. Okay? The places is in northern Argentina. This is Corrientes, one of the poorest provinces. And we wanted to work mainly in first and second level small hospitals in which a significant proportion of the deliveries are attended by only one person, or at least 2, but one is going to, let's say, go with the baby, and the other, only one, will remain with the woman. So we thought that Unijects could facilitate definitely, let's say, the administration of oxytocin, and also do it, let's say, within this 1 to 3 minutes period from delivery. Results, very, very quickly. You can see here 5 hospitals. After the 6 months, let's say the increase was dramatic. That's true. The increase was dramatic, and we reached more or less 80% of the deliveries receiving oxytocin. Look, this hospital, this particular hospital, this happens every time. After this first initial seminar, let's say, this is a province in which there is a regional guideline promoting the use of active management, for example. This person, okay, that's fantastic. The project is fantastic. I'm going to begin to use active management just now. Okay, well, do that. So one of the 5 hospitals, just when they only, let's say, this initial seminar, changed their attitude. But the other 4, no. So we needed the intervention to do that. Another very important point, we are extremely, let's say, worried about, let's see, safety issues. I will not be tired, let's say, to mention you that, because we are trying to promote preventive interventions. Most of the women are not going to present, let's say, severe problems, but we need to be sure that what we, let's say, promote is safe for them. So in that sense, we need to analyze this data. But in general, I would say that there was a reduction in the use of uterotonics postpartum. For example, manual removal of placenta has not increased, and we need to observe what happens, for example, with this drainage of vulvar hematomes. These are preliminary data. We also did a survey specifically to birth attendants. in baseline, and in most of them were the same, but not all of them, just post the intervention period. Here are some of the responses. Let's say almost all of the birth attendants have heard about active management, and actually they say that they knew, what were the definition and the effectiveness. But as you can see, here, almost 100% of them, the opinion was that it was highly effective, for example, but only 1 in 4 actually have used that. That changed after the intervention. So that opinion now are probably, better supported than in baseline. Look, the other important, issue is regarding the Uniject. We ask them only, of course, after the intervention period, if they use the Uniject, actually almost 100% of them. When comparing Unijects with using the vials, for example, 9 out of 10 thought that it was simpler to use. And also, we ask if Uniject were not available, do you think that the prophylactic administration of oxytocin would be reduced? Almost half of them, mentioned yes. Perhaps also we can say that some kind of, complementary bias could be there. But nevertheless, we always try to train them, to use both ways to administer oxytocin. And we try to not to be biased in that sense. So our preliminary conclusions are that this 3-component intervention is feasible in the context of a small maternity hospital. It is probably effective. We are not sure, but it is probably effective, to increase the use of prophylactic oxytocin, CCT, and uterine massage. I didn't show you the effect, but uterine massage, increased from 50 to 70%, and CCT increased from 30 to 75%, more or less. And also that Uniject was well accepted and used by birth attendants. Okay, congratulations to POPPHI, and thank you all.
Exquisite timing. All right, let's follow that with Ezequiel Garcia Elorio on how research was informed practice in Ghana. Thank you.
Thank you. Well, good afternoon to you all. You know, I once attended to a presentation where 80 slides were shown in 10 minutes. He did it. I will try to do as he did. You know, the objectives, I had a co-presenter, which is Dr. Nelson Damali from the Korle-Bu Hospital in Ghana, but he couldn't make it today, so I will try to replace his part too. So the objectives of this presentation will be to describe the Cambio intervention that was deployed in 2 hospitals in Ghana during this year. The preliminary results will also be presented, and the most important thing will be to share with you the lessons learned, because this project meant a different, Fernando just told you about a research project that was published and released as very good evidence, but now the challenge of replicating it in a different setting was very important. And that provides us with that challenge, because something that should shown to be effective in Argentina and Uruguay has to have the same result in a different setting, and Ghana was the country chose for this, and the Ghanaian Health Services was also very generous to provide us the opportunity to do this in their country. So the problem is very well known to all of you. The baseline Ghanaian hospitals, the use of AMTSL was not that very well deployed. Only 3% of them were doing it, as the same as the guidelines trial. And the questions we had is how we can reduce the gap between research and practice, and how we can promote behavioral change among birth attendants. The explanation or answer we have to this question was Cambio. This acronym was created by Pierre Buchans from Tulane University, Change in AMTSL Behaviors and Obstetrics, and the POPPHI and USAID funded this replication in Ghana in 2 hospitals, Korle-Bu in Accra and Kofanoche in Kumasi in the Ashanti region. The work done has 3 stages. For us, The first stage was the most challenging, since we have to adapt all the materials that were used in the trial to be used in Ghana. So we have translated all materials to English, and afterwards we have been communicating with the Ghana team for many days, for many months, just trying to adapt those materials for the country. Then we visited the country for a 2 weeks period, where in the first one we visited the hospitals, we talked to the facilitators and people that were going to participate in the intervention, and then we deployed the intervention itself. The most important thing of the Cambio intervention is the selection of facilitators. This is an intervention planned to train the trainers. It has to move itself. So a peer selection process where all the birth attendants select facilitators because of their, for academic reasons, humanistic reasons, also for communication reasons. So those people have the skills to replicate, to disseminate knowledge among them. So we did all the techniques, we reviewed with them all the techniques that Fernando just told you about, the evidence-based medicine review, academic detailing, the use of reminders and feedback to participants, training in manual skills, and also training in quality improvement initiatives, because this is mainly a quality improvement work. And then we didn't let them go without having a work plan. So they created a work plan, and thus was the master plan they used whenever they got back to their hospitals. Finally, during the period that followed the intervention, we contact them by phone and email regularly, not as much as we should have done it, as we are going to mention afterwards. And also we did a site visit, where we did the monitoring and evaluation of how the intervention was conducted. So what this hospital done is to follow the plan they have developed to disseminate AMTSL among the peers. The things that they identify as useful is to make changes in the delivery book, where AMTSL, the oxytocin delivery was registered, but the time of the delivery, the timing was not registered, and the other components of AMTSL were not either. So they changed that, as I'm going to show you, and they also created a program to disseminate the AMTSL's knowledge. And here comes one of the other issues that's very important for the intervention, is that the coordinator should be in place in every hospital to monitor this for their own sake. So as you may see here, during the seminars and the training workshops they held with the peers, they try to practice the work of delivering AMTSL the correct way. One thing about the reminders, they had the POPPHI reminders in place. That's what we saw during our site visit. But we suggest them, and they agree, and they did so, to develop new reminders, which have their own image. So it's very important for them to have the correct knowledge, but also with this cultural view. As you can see here, they created a stamp, and the stamp was used in their delivery books and the charts, where they can register in more detail how AMTSL was provided. Finally, you can see here some process measures. Here you can see from Korle-Bu in Accra, Ghana, one of the percentage of people that have attended the seminars. You know, as you can see, there were 287 birth attendants in that hospital, and it made 76% of them to attend the seminars. And that might be not enough for a trial, but it's reasonable for what they have been doing. There you have the self-registered, the self-reported compliance with the providing of oxytocin in time that increased from 88% to 95%. And then the preliminary findings. You know, Cambio is based on it's a pre-post evaluation. It has a baseline and an intervention and a follow-up period. There you can see that the compliance with the 1 minute delivery of oxytocin and the other components of AMTSL was very low, 11.8%. And after the intervention that was conducted 3 months before the evaluation, it increased to 20%. It's not that high, but in terms of improving and sustained improvement, it was a change. And as Deb told us, it's very difficult to change behavior in teaching hospitals. Conclusions. Cambio intervention was successfully adopted in the participating hospitals. It proved to be acceptable. It's not yet finished, but we hope that it can be sustained and the improvement can continue along the time. People were very motivated. More analysis should be done in why were the reasons not to comply fully. and we hope they can be scaled up to district hospitals. And finally, I hope Linda lets me, what are the lessons learned? What we should do again to use research-proved techniques in the field, to have a liaison like Dr. Joe Taylor, who was a PAPPHI consultant and really proved to be very helpful, to be very rigorous in the facilitator selection processes, to understand the importance of good selection of hospital coordinators, to give special attention to cultural issues, to ensemble a team that we did of researchers and practitioners, then to conduct conference calls as needed, and to conduct a monitoring visit as we did. What we should try to change for next time? Well, we don't want to ask for more money, but we'll ask for more time. We'll hope to have more time to conduct, not to conduct an intervention, but to follow up and to continue the monitoring. Then be more insistent on remote follow-up and provide whatever means are needed to maintain the plan scheduled. And finally, the hospital coordinator took much responsibility. They have to delegate a little bit in their peers to make this work. Finally, this was the people that attended the seminar. This is Alicia Aleman that joined the trip with me, and over there the tallest guy is Nelson Damali, who should be here today and was one of the coordinators from Corlebu. Thank you very much.
Well, that's impressive. You see how challenging it can be to introduce this in varied hospital settings. So finally, Matthews is going to talk to us about WHO.
Good afternoon, everybody. You know why I have to rush? Partly because I have to catch a plane, and also because some of the data which I was supposed to present has already been presented by Beverly. So thank you very much for shortening my presentation. What I'm supposed to, well, I thought I'd just share what WHO has been doing in the area of translating research from research to practice in the area of postpartum hemorrhage. So these are WHO's core functions. I heard we are a very conservative organization, and the reasons why we are conservative, we are catering to 193 countries, and we have to articulate consistent ethical and evidence-based policy, etc. So I'm not going through these details, but these are available on the website. This is a WHO maternal and perinatal research network, which has been involved. Many of these countries and many centers in these countries have been involved in generating the data which are available and have been made available for developing guidelines. In the clinical trials, in the area of postpartum hemorrhage, the multicenter randomized trial of Misoprostol in the management of third stage, that was published in 2001, and you have the more recent one, which is the WHO Genuity trial of Misoprostol as an adjunct. There has been synthesis of research findings, the systematic reviews on maternal mortality and morbidity, the SAM or the near-miss reviews done by some of my colleagues. Then there's the WHO analysis of cause of maternal death, again a systematic review, and the findings from that review are shown here, highlighting hemorrhage as one of the important reasons for maternal death, and the numbers, the proportions of maternal death which are due to hemorrhage have gone up, at least from the systematic review. The other systematic reviews are in the area of prostaglandins in the third stage of management, Misoprostol for prevention and treatment of postpartum hemorrhage, and more recently on dose-related effects and maternal mortality related to Misoprostol. There is a review which is going on the safety of Misoprostol. Of course, translating research from practice, there's technical support that WHO provides to countries to implement these PPH prevention strategies, and of course treatment also, providing evidence-based guidelines. The impact guidelines are the ones which are widely available. We have training modules for midwifery, the midwifery education modules, as well as the other modules which for training. It's part of the essential medicines list. There are drugs or medicines for prevention of postpartum hemorrhage. We also have costing tools which help you to cost how much does it cost, what resources do you require for prevention and for treatment of postpartum hemorrhage. And finally, there are data on monitoring and evaluation. Now, these are the guidelines. 2006 was the consultation. Again, there was a lot of support from POPPHI and USAID for this prevention meeting, and some of the people around here in this group were at that meeting. This was the first of the WHO guidelines that we have developed using the new system of grading based on the WHO guidelines for guidelines. So, okay. So now we are also working on a checklist, and soon we'll have a checklist for checklists. Right. So I'm not going to go through this, but you will find that some of these things have already been shared earlier, so I'm going to skip these. Controlled contraction is the one where there is some control. I mean, is it required or not? That's where the research is being done, and this is the trial which is being currently done. Active management of third stage of labor without controlled contraction, a randomized non-inferiority controlled trial, quite a mouthful. But the fact is, what we want to do is to see whether there's any advantage of not requiring, the contraction requires additional training to do this manual skill safely, and is it not less, is the simplified package without controlled contraction not less effective than the full AMTSL package? And the trial interventions are this. One arm has management with the standard AMTSL package with controlled contraction, and the other arm without the controlled contraction. This is the latest from my colleague Metin Gulmezoglu, who unfortunately couldn't be here today. So as of November 9th, they have recruited 4,045 women. The sample size is about 24,000, so hopefully by the end of next year, they would have data available for analysis. This is the more recent guideline on the management of postpartum hemorrhage, and this again, Beverly has highlighted some of the recommendations which have come from this. To go back, at least for the management of postpartum hemorrhage, very little has changed since 2000. Practically, very little has changed. Most of the drugs of choice are the same. And I'm not going to do this because Beverly's already covered that. Okay. The most recent one is a WHO statement on misoprostol for the prevention of postpartum hemorrhage, prevention and treatment of postpartum hemorrhage. And these are some of the issues which have been highlighted, that active management with oxytocin is recommended for PPH prevention. And in the absence of personnel to offer active management, trained health worker should offer 600 micrograms orally, misoprostol orally, immediately after the birth of the baby. But in such cases, no active intervention to deliver the placenta. In other words, don't pull on the cord. WHO is not, the essential medicines list does not currently include misoprostol for prevention of PPH. And what I've listed here is verbatim from what the report of the essential medicines of the expert committee for medicines is included. And I think I'll stop at that. No, I think I'll stop. If you want to leave, I'll leave it a little longer for you to read it, because these are mostly verbatim from that. Okay, and this I think is very important to WHO does not currently recommend distribution of misoprostol to community health workers or women and their families for routine or emergency use. And WHO recommends research at the community level to investigate how PPH can be managed effectively at this level. And that's something I'd just like to share with you. Thank you.
Well, this is good evidence for the fact that we leave our most important conclusions till the end. So hopefully you will ask us your most important questions, because we don't have all that much time. So please, let's ask Matthew the first questions so he can leave for his 2 o'clock flight. Any questions? Yes. Koki?
Thanks. My question is for Matthew. So I wanted to ask a question about the trained health worker. That was the recommendation that they can provide misoprostol, versus your last slide where you said in the community setting it should not be given, whereas in many cases it would be the community health worker who would be in the community setting. Okay. How do you count them?
Okay.
Very good question. Right.
Okay. That's a common question, so I will just answer the way we normally answer that.
He just happens.
And I can see at least three people here in this group who were there at that meeting. And basically it's based on Richard Derman's study from Belgaum, where auxiliary nurse midwives are involved. And it's a very good study. It showed that it reduced, misoprostol reduced thing. But auxiliary nurse midwives, strictly speaking, do not fall under the skilled birth attendants. But all of us know who worked in India that they do a lot of work. And in fact, my younger days, they were much better than doctors. Right? Yeah, so that's the reason why it was called trained health worker rather than a skilled provider. Okay, that's a lot different from some other categories where you have very short, you take these tablets, give it to them. That kind of training, we need a lot more intensive training for this work. Richard.
Yeah, so thanks for the plug. I'm so sorry we didn't have more time for this really excellent panel and to hear the good work that Ganuity has done to confirm our work initially in India. And I think it's an important statement to make that when we go to big pharma and we see what's required to get approval of a drug and its use, it usually requires 2 major pivotal trials. And we now have 2 major pivotal trials. We have our study, we have Ganuity's study confirming our results, soon to be published. And we're hoping that the folks around the room that have lots of home births, lots of village births, recognize the importance of this as we see the data play out. I'm not going to take Matthews to task in comparing the numbers of people who die from postpartum hemorrhage compared to the potential side effects of 600 micrograms that have been used in almost every study of misoprostol. I do want to make one more statement because Beverly raised a very good question early on, and she said, do we really have outcome data with mortality and morbidity? And this is a plug for Linda and the NIH Global Network. We have 7 countries where we have registry data, which is really better than government data. So we monitor every birth and every death of babies at 4 weeks and at mothers up to 6 weeks. And because this is a collaborative audience, we really urge you to consider utilizing our registry in these countries, in Africa and Latin America and in Asia, to go ahead and conduct trials because we already have the baseline data and it's been validated. So thank you for all your good work.
Great. Okay, let's have questions for our other 3 speakers, unless there's something really urgent from Matthews. Okay, questions for the other 3. In the back, yeah.
Just a quick question out of curiosity for Beverly. As you've designed your studies with your colleagues over the years and the ones you're thinking about doing in the future, have you ever even had discussions about whether or not we need to be thinking about traditional uterotonics, traditional preparations that are believed to be uterotonics?
Could everybody hear Cindy?
I guess the short answer is we haven't had that discussion in the context of planning our studies, but we have had discussions of those issues. Those preparations are, we don't know what the active ingredients are. We don't know what the concentrations are. We wouldn't know what to do with it. So it's not a substance that one could use elsewhere, and it's very interesting. And there's a whole sort of pharmacology about biologicals and, natural plants and things that would need to be undertaken. That's not our expertise,
We tried it in Tibet. Misoprostol was more effective. Yes.
Yeah, can I ask Beverly to sort of speculate on, now that the data is available for her from the additional studies or about to become available, what it would do to the current recommendations as they stand?
Well, yeah. 2 things. I think the EML review was on the cusp of the prevention to put it on the EML for prevention, and it's the hope that this new data, the new analysis, will provide enough additional information of exactly the sort that they asked for them to be able to put it on the EML. So that's, if everyone is an honest broker and everyone means what they say, it should be enough. But we'll see. We don't know. And then I think that finally for treatment, there's a potential regimen See, before the studies were so variable with doses in multiple routes and different amounts, and now these studies have treated almost 1,800 women with the same dose and the same route, and that's much more than the entire existing literature. So there's finally 2 studies with the same dose and the same route, and probably one might be able to make a recommendation. I don't know. We'll see.
So everybody understands that you're recommending that 600 milligrams in these 2 very large studies might result in its being listed on the WHO essential drug list?
The one additional study that Dick Durman was just talking about was 600 oral for prevention,
right,
which confirms the previous studies. So, and since all the studies really have used that was never in question, the dose for prevention. But the dose for treatment, which is the one that has been all over the map, now there are many more cases that have been treated with 800 micrograms sublingual misoprostol. And so that could become, for the moment, until someone makes a lower dose, shows that a lower dose is as effective, it would seem to be standard.
Okay, good. The next question? I don't see who it is in the back. Jennifer. Somebody. Oh.
Hi, Matthews. I was just going to ask, given that there are going to be 4 or 5 new studies coming out, I think 5, because Justice also has a study on prevention that'll be coming out in the next year or 2. The papers Beverly mentioned have already been accepted at Lancet, so the PDFs should hopefully be coming to us any day. What would be the steps to request a revision also of the 2 sets of guidelines, the 2007 PPH prevention guidelines and the 2009 PPH treatment guidelines that obviously, or I believe would warrant a revision as well in light of this huge amount of data?
Well, when are we likely to get the data? Sometime early next year?
Published?
Yeah, published, yeah.
Sometime around the beginning of the year.
Because, some of the data which we already have included were unpublished data, if you remember the thing. So that, well, to be honest, I think it will take some time, because firstly, to have a meeting, you need money. That's quite expensive. But certainly when we are updating our impact guidelines, we'll look at the evidence once again, and perhaps another 2 years or so before we have something. Okay. I'm looking at Mary Ellen if she's got any money.
Mary Ellen, do you want to add anything? Where are you? There we go. Spotlight on Mary Ellen. We had another question. Oh, yes.
Yes, thank you very much. I was hoping Matthew would be here when I make my presentation because I'm doing Oluwole. I was going to talk about this, and hearing you say now that it will take 2 years worries me, because I do know that WHO Regional Office for Africa has already advised countries to stop the use of misoprostol. Yes, because they are not recommending it. At the same time, we have countries that have already introduced it, even in the essential medicine list. And when WHO speaks, countries listen. But women will continue to die for 2 years. I think we need to expedite action. Thank you.
Thank you, Doyin. This is a very, very popular. I mean, this is definitely a very emotional appeal. But part of our problem is because our emotions got ahead of the evidence. Okay, and a lot of this problem started because of that. I mean, I don't want to go into details because I guess most of you know what I'm talking about. And we can sit here and debate till, till my plane leaves. But that's a problem, because what we need is good quality evidence, which we have now from Richard's study, and I'm sure the data will come from Beverly's studies also. But what we have recommended, if you look at it, is don't allow it to be given to community workers who are not adequately trained. Don't give it to the woman and her family. We don't have enough data. I know there's anecdotal experiences, there are other things which are published, but these are not really good quality data, based on which we can make a recommendation. I mean, we can go on, Doyin, to discuss.
Can I just make one point about that before you leave? Women are dying from misuse of misoprostol given by doctors for induction of labor. They're not dying because women have used it wrong at home. So...
Okay. We don't have. All I can say is we don't have documentation. Okay. When you have a problem with misoprostol, how often is it documented? You're using a drug for something which is not, well, in your country it's not legal. Would you report that? Is it reported in the journals? Where do you report? Yes, we know. With oxytocin, it is. We know it's documented. We know it's documented. We also know that one injection of oxytocin IM, it's a common practice, used to be a common practice, at least in India. You get the baby, it still probably is a common practice in India. It actually makes the uterus contract, you can hyperstimulation, you can occasionally get a rupture. But take 200 micrograms of misoprostol before delivery, and things are different. That's all I can say. I mean, we don't have documentation, I agree. But this is a possibility, a reality.
Fernando?
No, I think that the point here is that I definitely support what Matthew is saying. Let's see, we don't know actually what's happening because we don't have documentation. So before we have the documentation, we should stop.
Thank you. It is being done. I know it was done in Indonesia. I know it's been done in several other countries, and that's why we need to get rigorous data where this work is being done so that we can show that in the hands of women and lower-level providers, it actually is not only effective but safe.
It sounds as if we have a charge, and we'll end with that. Thank you very much. And remember, you can ask 3 of our speakers all your questions off stage.